So good morning, everyone. Welcome to the 2022 Diversity Grand Rounds. The Diversity Grand Rounds are organized by the Diversity Council, and Dr. Bacchus is here as our invited professor for the 2022 Diversity Grand Rounds. And she's a very special guest, as she was one of the original members of the Diversity Council during her tenure here at UW as faculty in the Division of CT Surgery, and also as a section chief of thoracic surgery at the Puget Sound VA. And she was here from 2009 to 2015. And we're very excited to welcome you back to UW. And unfortunately, due to the pandemic restrictions, you're not able to be here in person. We're looking forward to giving our residents the opportunity to meet with you. So as we discussed, we are going to have a rain check. So a little bit more about Dr. Bacchus. She trained in general surgery at the University of Southern California, and she did her cardiothoracic surgery training at UCLA. She's currently an associate professor in the Department of CT Surgery at Stanford University, and she's also the section chief of thoracic surgery at the VA Palo Alto healthcare system. She's currently a director at large on the STS board of directors, and she holds multiple leadership positions in the STS, WTS, ACGME, SUS, and a number of other high-powered academic societies. Now, as an educator, Dr. Bacchus is the Associate Program Director for the Thoracic Track Residency Program, and she's also the chair of the ACGME Residency Review Committee for the thoracic surgery, which is the accrediting body for all cardiothoracic surgery training programs in the United States. And to speak more to her dedication for teaching, she was awarded the Thoracic Surgery Residents Association Magoon Teaching Award a few years back, and she was also inducted into Alpha Omega Alpha Medical Honor Society, which we're all familiar with as a faculty inductee. So she has a track record of dedication for teaching. She's also an experienced health services researcher, and she serves as the co-director of the Thoracic Surgery Clinical Research Program. And as a member of the National Lung Cancer Roundtable for the American Cancer Society, she currently serves as the chair of the task group on lung cancer in women, which is a big deal. Her current research interests, which we're going to hear about more today, are in imaging surveillance following treatment for lung cancer and cancer survivorship. And Dr. Bacchus is the quadruple threat. She's an excellent administration, she's a clinician, she's a teacher, and she's a researcher. And I am very honored to welcome my mentor and my friend back home for the 2022 University of Washington Diversity Grand Rounds.
Thank you so much. It is such a pleasure to have been invited, but it's always a pleasure to be invited back somewhere where you've been before, right? So at least that goes to show that you've made some sort of positive impression with your time spent there. So this is really a pleasure for me. It's bittersweet, of course, because it's virtual, but nonetheless, the honor is still there. So without further ado, I'll go ahead and start sharing. Hopefully you guys can all see the slideshow. So today I will talk about how it is that we can move towards a patient-centered approach to surveillance after treatment for lung cancer. So this is the distribution of stage at the time of presentation for lung cancer patients, at least historically so. So this is data from 2010 that, as I said, shows the distribution of stage. And what you can tell from here is the fact that the majority of lung cancer patients are being diagnosed at late stage disease, at least historically so. And that's, of course, important because we in the world of surgery have the most ability to impact patients' outcomes, et cetera, when they're diagnosed with earlier stage disease. So this is a little bit of a poor backdrop. But if you look at the distribution in terms of stage at time of diagnosis from the National Lung Screening Trial, which was published in 2011, we think that the scene gets a bit brighter. So the NLST, for those who may not be familiar, was a huge landmark study in the world of thoracic oncology because it was a 53,000 patient study that demonstrated for the first time that at least in high-risk patients, if we're actually able to conduct screening for them with CT scanning, that not only are we able to see a shift in the distribution towards earlier stage disease, which is fantastic and the ideal outcome for any kind of screening program, but this was also associated with a 20% reduction of mortality, which is great news. The Nelson trial was published soon thereafter and demonstrated rather similar results. But the point being that as we're able to have more ubiquitous uptake of lung cancer screening for high-risk patients, that we should see this stage migration with earlier presentation of disease, and therefore patients who are at risk for longer period of time for recurrences and for development of second primary lung cancers. So when I was a brand newly minted CT surgeon coming out of training with my first job there at University of Washington, this is what I was thinking of, kind of the bigger picture in terms of how patients present for their screening all the way up to surveillance. So they're going to ideally present with an early stage lung cancer detected by screening, which is fantastic. We talk about them at our tumor board, then I'm able to operate on them, which is great. I see patients in clinic post-operatively. You're doing wonderful, recovered well from your surgery. And then I kind of felt like both the patient and myself were sort of looking at one another like, okay, now what? You know, this is great, but what do we do from here? So I thought about it, and as I said, in the broader context, and the question was, well, they should have some sort of surveillance, but why? What is it that we're really trying to achieve with cancer surveillance after treatment? Well, ideally, we want to improve their cancer-specific survival, their overall survival. We want to be very judicious in terms of how we roll this out, such that we're mindful of cost and burden to the healthcare system. And ideally, we want to make sure that we're improving the patient's quality of life all at the same time. But if you back up and look at just what does the epidemiology of cancer recurrences and development of second primary lung cancer for patients with non-small cell anyway, this is what that looks like. And this is a little bit of a dated chart, but I think it was really nice because it demonstrates in the solid line what distant metastases looks like in terms of this trimodal peak of distribution. And then you also have the dashed line, which is local recurrences, which is much, and this is all comers, of course, which is much smaller peaks, but nonetheless, not a nice bell-shaped curve. And then the bottom line, which I've highlighted in red, is the risk of second primary lung cancer. And that risk is estimated at about 1 to 6% per patient year, or cumulatively about 13 to 20% for patients. So definitely not insignificant. And as I'd mentioned before, if we're shifting the stage at the time of diagnosis to earlier stage disease, that cumulative risk is something that's really important. We need to keep an eye on. So historically, what have we had in our armamentarium in terms of surveillance? Well, we had things like sputum cytology, which really, again, has no proven benefit and very weak data extrapolated from screening studies. There's bronchoscopy, which obviously is an invasive procedure and carries significant risks associated with it. And again, there's no proven benefit here. There's more functional imaging, sophisticated imaging like PET scanning, which is great in terms of specificity, but PET scanning is not necessarily ubiquitous in terms of accessibility for all patients throughout the country. And there's still, again, no proven benefit in using it as a surveillance medium. Then there's patient report, which is kind of the lowest fidelity intervention of all, which is let's just see if you develop any symptoms and then go from there. This is our go-to resource, at least for many of us that work in the oncology space, are the NCCN guidelines. And this is what the singular surveillance slide has looked like within these guidelines, at least up to 2016. You can see it's a fairly bland slide. All patients are lumped together, no special considerations for cancer stage or treatment rendered, but all patients are nonetheless recommended to have a CT scan, which can be done every 6 or 12 months for the first 2 years, and then a history and physical and a low-dose CT done annually thereafter. But this is what the recommendations look like at the time. And if you look to see what the data were upon which those consensus guidelines were based, it's kind of all over the map, but for the most part, relatively low level of evidence. So this is just a slide that demonstrates some of the heterogeneity here. We have a mix of retrospective and prospective studies. relatively small sample size. Many studies actually have no comparisons. So they've just said, well, if we looked harder, we're able to find more recurrences, which is not really earth-shattering news. But basically, this is the level of evidence that we had. And so you can understand then why the recommendations were relatively loose, if you will. There are other organizations, obviously, that people can go to. And if you just looked at the first 2 years after treatment, these are what some of those recommendations historically have looked like. So you've got the American College of Radiology, American College of Chest Physicians, ESMO, NCCN, and ASCO. And the recommendations are really kind of all over the map. Most of them do recommend CT or favor CT over chest X-ray, but in terms of intervals and frequency, there's really no consistency there either. So my first question, like I said, as a fledgling researcher, was how are we actually doing? If we just took one iteration of the guidelines to follow, in this case, the NCCN, how is it that we're doing with regards to adhering to what we have anyway as our best recommendation? So to answer this question, my buddies and I, there at the University of Washington, embarked on this study using Serum Medicare data. And so we mapped things out in terms of the time to diagnosis to 24 months after surgery. We labeled T0 as the date of surgery. And then at least theoretically, patients should get a postoperative visit with a chest X-ray very early in their postoperative course. And then outpatient postoperative course. And then they have clinic visits and CT scans, which should be marched out at 6-month intervals afterwards. Well, we decided to hone in on that first interval for surveillance at 6 months. And the reason for doing that was because you can imagine using Serum Medicare or any claims-based data that we have no ability to know the reason or the indications for which a study is being ordered for any of these studies. But we thought at least if we were able to kind of try to have a more purist view, let's just hone in on that first 6-month CT scan. And we liberalized a little bit to say it could be done within the first 4 to 8 months after surgery. But let's see what's happening there. And this is what we found. We found a pretty poor result. Only 25% of patients were actually getting a CT scan as their initial surveillance study within that first surveillance period. The majority of patients were getting a chest X-ray. And you could liberalize things a little bit further and say, okay, what if we don't treat these mutually exclusively, such that you could have had a chest X-ray prior to your CT scan, but again, confining things to that first observation window. And the adherence rate went up to 48%, but nonetheless, less than half of patients are getting guideline recommended care. And just to emphasize this again, these are all patients who are otherwise alive and should have been eligible for surveillance. So this is not just necessarily taking all comers. The other thing that we found with this study, which was probably the most striking actually, was the fact that there were certain factors associated with non-receative guideline care. The two that jump out the biggest to me were patients who have stage 1 disease and patients who had surgery as their sole therapy, which is incredibly sobering if you think about it, because these are exactly the patients that you want to populate your thoracic surgery clinic practice, right? Are patients with early stage disease who therefore are not recommended to have any adjuvant therapy. They never even see a medical oncologist, and that's probably part of the problem. This is a study to highlight a little bit of a different view. The authors also use Serum Medicare data. It was published very soon after the prior study that my colleagues and I did. And basically, they tried to use some more elaborate criteria to get around the fact that you didn't have indications for the studies being done, but looked at things further out beyond that initial 6-month period. And the bottom line here is that there are some improvements in terms of adherence over time, but overall, the adherence to CT as a mechanism for surveillance is quoted as 61%. So not that much different from that 48% that we reported from our study. This is a little bit of a dated picture, but nonetheless, I think it captures my next question, which was, well, who's minding the shop? Whose job is it actually to be doing this? So if you're going to determine the fact that adherence rates are low, the next question is, who's supposed to be doing it so that we can come up with interventions that are going to actually improve upon that number? So to do that, we went back to our same Serum Medicare data set. And for this analysis, we went ahead and pulled all of their clinic visit claims and all of their imaging claims. We married those to the provider's AMA UPIN to figure out which specialty was actually doing what. And so we analyzed 1.7 million outpatient visits and 217,000 imaging tests. And in doing so, this is what we found. Well, on the positive side, 98%, so the overwhelming majority of patients actually had an outpatient clinic visit happening within the first 4 to 8 months following treatment. So this is really important because if you're going to say things like only 50% of patients are getting guideline concordant care, one question is, are they being lost to follow-up? Are they even showing up? And the answer is no, they're not being lost to follow-up, and they do have connectedness to care. So that's not necessarily the root of the problem. If you distill things out further and say, well, who are they getting their care from? By and large, patients are getting care from their primary care providers, which makes infinite sense. Again, if you consider the fact that this is a Medicare population and they're otherwise connected to care pretty well. With regards to the lung cancer specialists, the frequency with which they're visiting these providers are much less. They all kind of distill down to about 20% of outpatient visits by the time you get at 5 years out from surgery. So, and again, these are all, these are not all surgically resected patients, but these are all patients who underwent definitive treatment for their lung cancer. And why this matters is because who you see is going to largely dictate what type of surveillance that you get. So if you see a surgeon, a pulmonologist, or primary care provider, by and large, you're going to get a chest x-ray rather than a CT scan for your surveillance compared to seeing a medical oncologist or a radiation oncologist, whereby your chances are much higher that you'd actually receive a CT scan or a PET scan as opposed to chest x-ray. So the next question we had was, is this just like a US phenomenon, or is there something that can be gleaned from looking at global perspectives with regards to surveillance strategies? So we undertook this survey where we queried surgeon members from the Society of Thoracic Surgeons, the European Society of Thoracic Surgeons, and the Japanese Society. And we asked them, what type of surveillance testing do you do for your asymptomatic patients after you've operated on them? And this is what we found. By and large, most surgeons were advocates for just a history and physical for their patients, which is fine. That's sort of low-lying fruit. But if you looked at imaging, then things started to get a whole lot more complicated. You can see some distinction here between, so for instance, the Japanese surgeon cohort, who were strong advocates for chest x-ray. 84% of surgeons were advocating for chest x-ray as preferred surveillance for asymptomatic patients, in contrast to the European and the American surgeons for the most part. Big differences with regards to use of low-dose CT as well. Very little usage or endorsement amongst the Japanese surgeons compared to the other two surgeon groups. And then I put these in red here because none of these exams are actually advocated by anyone's guidelines in terms of routine surveillance. But you can see here that there's a huge amount of heterogeneity. You've got, for instance, almost 40% of the Japanese surgeons endorsing brain MRI for asymptomatic patients. So clearly, there's a whole lot in terms of differences in providers' beliefs. So in summary, most non-small cell lung cancer patients do receive their clinical follow-up, so they're not necessarily lost to care. And this is dominated by primary care. So if you wanted to figure out somewhere to aim your intervention, the primary care setting would probably be important. And at least at minimum, you've got to make sure that you bring these primary care colleagues into the conversation about patients. Less than half of surgically resected patients are actually seen by their surgeon beyond that initial postoperative period, which is probably part of the reason why they are at the greatest risk for not receiving guideline concordant care. And an estimated half of surveillance is being done in accordance with at least the NCN Guidelines. So again, another sobering statistic. And one of the things that we've got to think about is one problem may be the fact that we really, at least I haven't talked about yet in this talk, made the linkage between more intense surveillance and improvements in survival. That connection, I would say, is tenuous at best, and I'll show some data to support that, that statement there. But we do need to figure out where is the sweet balance, because there are some unintended consequences associated with the screening the surveillance that we might otherwise recommend for patients in terms of increasing worry and anxiety. There's resource utilization, there's morbidity, and all of that has to be balanced against what we would think should be the perceived benefits of early detection and survival. This is a meta-analysis that was done to answer this question with regards to intensity of surveillance and survival. It's a small study, though, 62 manuscripts reviewed, but only 9 included in this meta-analysis, but nonetheless, about 1,700 patients. It was a mixed bag of patients, which I think it adds to some of the difficulty in interpreting things. But patients who had stages of 1 through 3, and they did include small cell patients. So that's definitely something to consider when looking at the results. But nonetheless, this is what they found, that as far as overall survival is concerned, there was a general trend favoring more intense surveillance being associated with improvements in survival, but this did not reach statistical significance. And then if you look at patients who were asymptomatic with their recurrences and survival, there was some signal here. So among these asymptomatic patients, there was an association with intense surveillance and improved survival to the tune of about 49% reduced risk of death. So this is somewhat positive and encouraging in terms of why we do what we do. Again, we went back to our Serum Medicare data set, my colleagues here and I, and what we found, at least if we looked at that initial surveillance period and then tried to extrapolate out to see what the association, if any, might be with survival, this is what we found, at least on our multivariable model, that there was about a 15% reduced risk of death associated with receipt of that initial CT scan. Interestingly, there was no significant difference associated with a pure clinic visit alone. And the other thing to note is that this effect was only demonstrated for patients with stage 1 disease. It did not hold true for patients with stage 2 disease. Now, methodologically, you can appreciate the fact that there would be some disadvantages to this particular analysis in trying to connect the dots as to why your initial surveillance scan might actually be associated with improvements in outcome. But nonetheless, this is what we found. This is a retrospective study that tried to look at that, but they did do some propensity matching, which is why I've actually included them here in the talk. They had about 300 patients who received chest x-ray versus 200 patients who received CT scan. Because it was retrospective, whether or not patients received chest x-ray versus CT was predicated only on provider discretion, so you can appreciate the opportunity for significant selection bias. But nonetheless, they had matched and unmatched outcomes in terms of survival, and basically they saw no difference. In fact, if anything, there was a trend towards improved survival associated with chest x-ray rather than CT scan in their unmatched data. But this kind of flies in the face of all the things that I've just reported in the prior slides. This is another study that was done using National Cancer Database data. So this is a COC special project. The study was done by Benj Kozawer. And what they did was they utilized the power, if you will, of the NCDB and the cancer registrars to stratify patients as to whether or not their first imaging surveillance was clustered around 3 months, clustered around 6 months, or 1 year following surgery. And what they found effectively was that there was no difference. So this was a really highly powered study, but again, the analysis was limited to that first surveillance scan. It was validated by the fact that these are highly trained cancer abstractors, but we don't have any additional data beyond this first surveillance period. Some of the issues I think that we have as we're describing results in this space are the fact that there's a lot of heterogeneity with regards to the outcomes of interest and even the exposure. So for instance, there's a huge difference, as we know, between patients who have recurrent disease that's locally recurrent versus distant recurrence, and whether or not a patient actually has a true recurrence versus a second primary tumor is also significantly different, in the outcomes in these two patient populations is significantly different as well. And then you have recurrences that are oligometastatic versus polymetastatic. And again, you can appreciate that that the outcomes associated with this various buckets of patients are considerably different from one another. But yet, if you look at the literature, often these are discussed hand in hand, all lumped together. This is data with regards to recurrences and outcomes that I wanted to share with you all. It's a study that comes out of Japan, and it had a little more than 3,000 patients. Again, a little bit of a mixed bag in terms of stage, but stages 1A through 3B, and that 3B group is a gray zone group for all of us who work within the lung cancer space. But nonetheless, they had 768 recurrences that they looked at, 21% of which were oligometastatic, 79% were polymetastatic. And most favorably was the fact that 67% of patients in the oligometastatic group were actually able to receive definitive therapy for their metastases. And in doing so, they had a really favorable 5-year survival. So 32% 5-year survival versus 10% for those patients with polymetastatic disease. So again, you can appreciate if I'm doing some sort of a study where I'm looking at surveillance and yet lumping these two groups of patients together, their outcomes are going to be potentially very different from one another and obscure my ability to be able to detect any differences between the two exposures. This is another meta-analysis. Again, small studies, only 9 that were included in this, but again, that underscores the fact that there isn't a ton of literature being published in this space. But nonetheless, it provides a nice summary that shows that perioperative mortality for patients who are receiving surgery for their metachronous or second primary lung cancer is very favorable. And the 5-year overall survival is still 46%, which is pretty massive when you're looking at lung cancer 5-year survival, if you consider the fact that it's only about 20% for patients presenting with stage 3 disease on a good day. So some of the strengths of the current data are the fact that we do have some series out there that are larger series that demonstrate some temporal trends and a little bit of a signal there that there are some improvements associated with time and that we're getting a little bit better at this. There are some significant weaknesses, though, I still believe, such that many of the studies are retrospective in nature and thereby also hindered by some of the crude outcomes like survival overall, as opposed to some of the more intermediary outcomes, which are probably important to report on as well. And again, what's missing is no clear indication as to the reason for which any particular imaging test is being done for a patient. You still don't know if these studies are being done for surveillance, for symptoms, or what have you, and you won't know that unless you actually have someone look at the chart, unfortunately. So they're small single institution series. And then the other thing to note is that there's relatively poor representation of women and younger patients. And I pull these two demographics out because it's important, particularly when you're talking about lung cancer in women and how that is still on the rise, and the fact that these patients are usually going to be younger at the time of presentation. So extrapolating from the Serum Medicare population, for instance, to these young female never smokers provides or carries with it significant challenges as well. So why not perform a randomized prospective controlled trial? Well, there's several reasons, and I wish Larry Kessler were here on the call because he would be able to attest to some of the numerous hurdles that one can run up against as you try to roll out some sort of prospective trial in this space. Most notably is the fact that there's a significant potential for cross-contamination bias between exposure arms, and I'll talk about some of that, but you could see in that survey data amongst surgeons that it's kind of all over the map in terms of who's doing what. So there's lack of provider equipoise, thereby leading to provider bias. And then, of course, we have patient biases too. So these are the main barriers to doing some sort of prospective randomized trial in this space. This was a study that spoke to the surgeon bias and lack of equipoise, if you will. So this was published by Keith Nonheim, and it was published in 1995. It was a survey amongst surgeons of the Society of Thoracic Surgeons. They had 768 respondents, and they were asking them about their thoughts regarding long-term follow-up for lung cancer patients. They found that only 44% of surgeons believed that there was a survival benefit associated with surveillance for stage one disease. And then only 25% felt that there was sufficient evidence in the literature to support its routine use. So I said, hey, let me call Keith. And so I called Keith Nonheim and I said, why don't we redo this study and see if things have changed in the past 20 years in terms of surgeons' beliefs. And so this is what we found. Is more surgeons in 2016 believe that there was a survival benefit for stage 1 patients. So this was very positive to the tune of 66%. And this held true even for patients with stage 2 and 3A disease, which was nice. But there was minimal change in the belief that the current literature actually supported this belief that there's a survival benefit And nonetheless, though, there was increased belief in the potential curative treatments for recurrences. So a little bit of a mixed bag, some positive findings that surgeons were perhaps a little less nihilistic than they had been 20 years prior, but you can still see that surgeons did not feel comfortable that there was a ton of data out there to support the practices. So part of the problem, as we refer back to that NCCN slide, is that there's this one-size-fits-all approach whereby if you've had your lung cancer and it's been treated, everybody gets the same thing, and hopefully that's going to portend to better outcomes for you. But again, we really have not necessarily definitively established that. So wouldn't it be neat if we were able to come up with a much more tailored approach to things? This is a study actually published by Nate Malberg, who was one of our prior trainees at the University of Washington. And so what Nate and Dr. Ferguson did was to say, at least hypothetically, what if you took patients who had curative resection for their lung cancer and did some sort of risk factor assessment for their local recurrence, come up with what their local recurrence hazard curve looks like, along with the 95% confidence intervals, and then overlay on top of that, clustering the intensity of their radiology surveillance so that it corresponds to those predicted peak incidences. And we do have some ability to do that, but really it's not being done consistently. This is a nice study that was published from a group in China, which just took some of the information that we have right at our fingertips. This is information we get immediately on our pathology reports for all patients. So it's pretty low-lying fruit. And what they were able to do was come up with a risk score that stratified patients into low, intermediate, and high risk. And they show very nice separation of the survival curves associated with their risk score. This is a little bit more sophisticated analysis, I think, done by Summer Han and some of my other colleagues at Stanford, which again takes some of the readily available variables that we have at our fingertips to create a risk score or risk stratify patients specific for developing second primary lung cancers. And what they did was they took this data and created their own proprietary risk assessment tool, which we're all very familiar with, going online and plugging patient data into risk assessment tools. So this is one of many, but this is specific to second primary lung cancers. And when you do that, you're able to get this prediction result that gives you the patient's 5-year and 10-year hypothetical risk of developing a second primary lung cancer. And then you get this little graphical representation, which is the green line for your individual patient, shows where they fall within low versus high risk, but also within the whole full distribution of all patients. And this can be a useful tool when it comes to counseling your patients as you're trying to tell them why they should have more versus less intense surveillance for their lung cancer. Well, what about molecular targets in lung cancer? Molecular targets in cancer, period, has exploded, and lung cancer is no different. This is just a graphical representation looking at some of the most popular molecular targets, if you will. Certainly, I'm not going to launch into a whole discussion of these, but the thing that I want to point out is the fact that they're important in terms of predicting prognosis, in terms of patterns of recurrence, disease-free, and overall survival. And obviously, they have implications with regards to their ability to be therapeutic targets for targeted interventions. There's also the promise of circulating tumor DNA, which is all very exciting and very sexy. We know that ctDNA can be a predictor of risk of recurrence. It can also be a predictor of response to adjuvant therapy. It can be a marker of minimum residual disease, and it can be a predictor of disease-free survival. So this is all very exciting with regards to circulating tumor DNA. And the other thing for surveillance in particular is the fact that earlier detection of recurrences is associated with ctDNA compared to conventional imaging. And some studies upwards of 5 months earlier than what you can otherwise detect on conventional surveillance imaging. So that's pretty promising. One of the main limitations, however, of circulating tumor DNA is the fact that not everybody has it. So again, it's going to be difficult to say something like this is applicable to everyone when we know for a fact that that won't be the case. I do think that we have evolved a bit, and yet we have not consistently applied some of these very basic prognostic indicators into our management and recommendations for patients in terms of the surveillance that they should be receiving following treatment for their lung cancer. But there is a little bit of a brightness on the horizon. This is the updated NCCN slide with regards to surveillance after completion of definitive therapy. And now you can see it's gotten a little bit more complicated, which is great. There are more words on the page. And the reason for that is that they finally started to stratify patients out as to their pathologic stage and the type of treatment that they've received. So what the newest iteration of the guidelines has recommended is that patients who have earlier stage disease or who've had chemotherapy should get their CT scanning for surveillance done every 6 months for 3 years, and then once a year for 2 years after that. If you have late stage disease, however, or if you had radiation as your primary treatment, you should have more frequent imaging than every 3 to 6 months for the first 3 years. So this is the first time in 2017 where the NCCN has actually broken out patient groups in terms of the recommendations. This is a study that my colleagues and I did at Stanford, which I think kind of underscores the importance of doing what the NCCN did. And of course, I can't say that they used our study to make those recommendations, but nonetheless, it's consistent. So this was just a small retrospective review, 162 patients who had a median follow-up of 57 months. We found 28% recurrence at a median of 29.5 months following surgery. And this is what we found with regards to the ability to detect those recurrences by CT scan. And because this was a single institution and done with chart review, we were able to very cleanly say which patients actually had recurrences and what imaging was done explicitly for surveillance purposes. But this is what we found, that stage 1 recurrences, CT detected, peaked at 25 to 36 months, whereas stage 2 patients peaked later at 19 to 24, earlier at 19 to 24 months. So if you're going to make some sort of assessment as to how you should be doing surveillance for at least stage 1 or stage 2 patients based on this limited data, you would say patients with stage 2 disease should have their surveillance done more intensely compared to patients with stage 1. Another way of describing this data here is the fact that stage 1 patients, 81% of which had the recurrence after 24 months compared to stage 2 patients, the majority of which had their recurrence detected before 24 months. This is sort of like the pièce de résistance, at least it was supposed to be. This is the French trial, IFCT 0302, which was presented at ESMO in 2017. One of the sobering statistics, though, is the fact that this was presented at ESMO, but only has been published in abstract form, and there has been no manuscript. So that always leaves a little bit of a bad taste in your mouth, like, well, what's going on? Why haven't they actually published a full data set? But nonetheless, this was the holy grail of this prospective randomized trial, looking at more versus less intense surveillance strategies. So they had patients randomized prospectively to either chest X-ray versus CT. The primary endpoints were overall survival. They did have some secondary endpoints, which they did not report on, but they were going to look at cost effectiveness, disease-free survival, post-recurrent survival, and quality of life. And again, these are some of those important intermediary outcomes that we'd like to see reported in the literature, but really have yet to be done. They started in 2005, so it took them quite some time in order to accrue 1,700 patients and 119 centers that were enrolling patients across France. And this is what their study looked like. A little bit of a heterogeneous group in that they had patients with stage 1A all the way up to 3A disease, but they also included patients with N2 disease, which again is a big deal because those are gray zone patients in terms of what's the best and most appropriate treatment for them. But nonetheless, they had about almost 900 patients randomized to each intervention arm of chest X-ray versus CT scanning. And the bottom line is that they found no difference. So overall survival, no difference. 3-year and 8-year disease-free survival, no difference in terms of the two intervention arms. So a bit sobering for those of us that work in this space. They went on to say that earlier diagnosis of recurrence, however, and second primary lung cancers, again, lumping the two together, which I mentioned was kind of a big deal, but that either of these occurrences was associated with CT scan more so than chest X-ray, but that this did not confer any significant survival benefit. And then probably the most I don't want to say disturbing, but the most shocking recommendation to come out of this was from their exploratory analysis, where they specifically looked at patients who had recurrent / second primary lung cancer versus no recurrence at 24 months. And they concluded that CT surveillance offered no benefit within the first 2 years for patients with stage 3 disease. So don't even image them. Basically, wait to see if your patient lives or dies. And then if they're still alive at 2 years, then go ahead and start your surveillance. And I don't know if this is very French or what, but you can imagine how that would go over when you're meeting with a patient that has stage 3 disease that you've just operated on and they're getting adjuvant therapy, et cetera. And now you're like, okay, great, see you in 2 years kind of thing. And let's see if that would fly here in the US. I'm gonna guess not. So in my eyes, this kind of pits these two sets of recommendations against one another, and that they're not very consistent. You have the NCCN, which is basically advocating for more frequent imaging for patients with advanced disease. And then you have this French trial, which is advocating for less frequent imaging for patients with advanced disease. And the fact that these are very inconsistent with one another, I think sort of sets providers up for a significant amount of decisional conflict as you're trying to figure out what's really going to be the best thing to do for your patient. And so then kind of by default, if you're able to do more, I think a lot of us just do more because we don't want to be the ones that did less and then your patient has a bad outcome. So why persist with more inquiry into this space? I think because, as I'd mentioned, there's still a significant amount of decisional conflict in that we need to define the population that's going to derive the most benefit from intense surveillance versus not. We need to still be good stewards of the healthcare system and making sure that we maintain costs and that we don't otherwise introduce additional unintended harm to our patients with what we recommend. Allocation of resources. And we also need to prepare for some of these emerging trends in terms of incidence and stage migration and special patient populations, the molecular targets. All of these things I think are completely unexplored still in this space. So enter ISALT, which is imaging surveillance after lung cancer treatment. And this is the VA Merit Award that I have in Palo Alto, which is in conjunction with my buddies in the Seattle VA still. And the goal of this study, because it's a VA study, is to determine the patterns of imaging surveillance and guideline concordance within the VA population. And then to figure out what's the association between receipt of guideline concordant care and clinical outcomes. But the most interesting aim of the study is the third aim, which is going to try to model the optimal strategy for individual patients based on the best clinical guidelines and pit those two sets of recommendations against one another to see who's going to be the winner. Where does the tie go to? So to do this study, we have the benefit of using very rich VA data. As anyone who works at the VA, perhaps Dr. Langdale on the call can attest to the fact that it's a little bit of a double-edged sword. It's fantastic because it's this huge pool of data that you can pull all sorts of information from. It can be very unwieldy to work with, but if you get in there, the rewards can be significant. But nonetheless, so we've got VA raw oncology data, which is important for our cohort identification and pulling out cancer variables. We have the central data warehouse that basically has everything else that we need in terms of clinical covariates and demographics for patients. And then we have this chart abstraction piece. And the reason that's listed there is because I want to try to fill in the missing piece to all of these prior studies, which is combining the benefits of a really large claims-based study with the granular detail of chart abstraction and what's going on with the individual studies, and then coming up with very clean definitions in how it is that we define patients as having recurrence versus second primary lung cancers, et cetera. So to do that, we harness the power of raw radiology text reports and clinician progress notes, which also live within the virtual world of VA data. Now, prior to this, I should back up to say that these are the benefits of this particular study. We're going to finally get that indication piece, as I've mentioned. What was the image being done for? For surveillance, for symptoms, for other reasons? what did the radiologists actually observe? So what were the findings? And then finally, what were the recommendations for follow-up? Did they get the recommended follow-up? Did the radiologists' recommendations follow their own radiology-based guidelines, et cetera? So these are all still unknowns, but using this data set, we're able to get to this degree of detail when it comes to reporting on some of the outcomes. So to do this, historically so, as I'd mentioned, in order to get that granular detail of data, you had to rely on manual chart abstraction, which you can imagine if you've got 18, 20,000 patients that you need to manually abstract charts for, that's like a forever endeavor. And by the time you actually have your army of abstractors that pulled all your data and analyzed it, your data is very outdated, right? So that just doesn't make any sense. It's not very practical. To get around that, many researchers, including some of my buddies here in the Seattle VA, have looked at natural language processing and machine learning, other computerized means by which we can pull out some of this data. But what we found, at least in looking at lung nodules in the same way and analyzing those raw radiology text files, looking purely using purely computer-based methods for doing so, the accuracy is really down in the dumps, like not at all accurate enough to actually do any high-level research with. So this is what we've come up with for this particular study, which is this semi-automated method that's going to combine the benefits of both. So we apply effectively computerized filters and search tools to distill the information down enough so that then we can have an abstractor come in and do the manual abstraction on this reduced data set to give us the accuracy that we need to make appropriate conclusions. This is what that looks like. This is a Leucine tool. So this lives within the virtual environment of the VA and basically is able to take all of these raw radiology text reports in this instance, categorize them, not categorize them, I should say sort them by patient identifiers. So we have each patient as a little folder, and underneath each patient, you have the various reports that we've pulled for them. And then depending upon the search terms that you use, of which you can use many, the tool is going to highlight these little snippets of text, which is going to make it infinitely more efficient for your abstractor to get what they need. This is what the abstractor then looks like. As they click on the snippets, they can see the search terms within the larger context, which allows them to make more accurate coding of the document. And then you have at the bottom there our validated data collection instrument, which has the drop-down menus for how it is that the abstractor is going to code this particular document. And so in doing so, we've identified our main cohorts. We've got 185,000 patients with lung cancer within the VA system, but we've distilled this down to 17,000 that met our inclusion criteria. And we have about 30,000 imaging reports that we're going to be analyzing. That's not even counting the clinician progress notes. But we had this training cohort of about 3,400 imaging reports corresponding to 378 patients. And we did the various iterations of our Leucine searches to refine our methods before applying these methods to the larger cohort. And this is what we found. We just did an image type query to weed out all of the extraneous imaging tests, the bone scan, the tagged white blood cell scan, et cetera, that are not relevant to our particular study. So we just pull these guys out. And then we actually looked to see how did Leucine perform, and she performed fantastically. So we had great sensitivity, specificity, precision, all of the test metrics really off the charts, which is fantastic. Well, we got a little excited and said, well, why don't we see what we can do with regards to the indications or the findings on some of these reports? And that's when things went down in the dumps again. So this is the test performance for looking for things like surveillance in the various ways that we tried to do those searches, and for characterizing imaging reports as being suspicious or not, or whether or not there was a recurrence detected. It's all over the map, basically. You can appreciate the fact that this is not at all the caliber of precision that we would require in order to feel confident about our data. But this just goes to show you, this is the inflection point, basically, that, okay, we use the computerized techniques as far as we can, and then we have our abstractor take over. And in doing so, we're actually able to reduce our chart abstraction time per patient from 21.5 minutes to 6.9 minutes, or 68% reduction in abstraction time. So pretty significant. We're still working on our main cohort and doing our abstraction, but nonetheless, we're really excited about this opportunity here. So lastly, I'll just talk about surveillance within the larger context of cancer survivorship, because this is just one of many components of what patients are going through at the tail end of their cancer diagnosis and treatment. And specifically, I haven't really talked prior to this point about the patient biases that come into play here, but they are significant. And shockingly, if you ask patients about their thoughts surrounding surveillance, they have many, and they're happy to share them with you. So this was a patient survey that we did while I was at the University of Washington. And these are just some of the quotes that basically show you that patients do have a significant amount of cancer worry. So if I'm going to recommend for you to have a CT scan every 3 months versus every 6 months, that means you're going to be scared out of your mind every 3 months versus every 6 months. So that's not a minor thing to consider when you're trying to come up with things that are going to actually help patients. They also come in feeling very insecure in terms of self-efficacy and the lack of knowledge that they have specific to their cancer diagnosis. And they also have a whole lot of opinions about what they should and shouldn't be getting. So as I'd said before, if you come in saying, hey, listen, buddy, we're going to not image you at all for 2 years, stage 3 patient, see how you do, and then we'll get it going, that's not going to fly. Or if you say, yeah, you know what, we're going to go ahead and just do chest x-ray because there's no proven benefit with CT scan, and the patient has had 50,000 CT scans up to this point, they're not necessarily going to be really enthusiastic about this lower fidelity test that you're recommending for them. There is something also to be said with regards to palliative care. If none of this pans out such that there are no differences and definitively demonstrated between more intense versus less intense surveillance, et cetera, intervals, imaging modality, et cetera, at minimum, we want to make sure that we're able to identify recurrences or second primary lung cancers as early as possible. At least for the latter, those second primary lung cancer patients, I still feel that they're a special group of patients, and we're going to have really good outcomes associated with them. But even when you're talking about patients who have really bad recurrences, distant recurrence, polymetastatic disease, et cetera, if nothing else, we're able to actually institute palliative care for them at the appropriate time frame, we can still be impactful with regards to their quality of life, and even with survival, as this study amongst VA patients demonstrated before. I think this is my second to last slide. So basically, I put this up here because I want to underscore the fact that the majority of survivorship evidence out there is not from lung cancer. There's a fair amount of nihilism when it comes to lung cancer, and I contrasted here with breast cancer survivors, not because there's any disparagement being thrown towards breast cancer survivors or breast cancer researchers, providers, et cetera, but just to show this huge disparity, if you will, or this huge dichotomy between these groups. They're not the same. You know, you've got female patients versus predominantly male patients. You've got younger patients at the time of diagnosis, better connection to preventive and chronic care. And then you've got the whole like negative stigma, blame, and shame associated with smoking in our patient population who are otherwise still the majority of lung cancer patients. So extrapolating from, say, breast cancer in terms of overall survivorship strategies to the lung cancer population, again, I think is a very poor fit, and we can do better at coming up with more tailored ways to meet their needs. So this is the final slide. I think we are here. I probably should have picked a less grim picture. It looks very dark and bleak and just awful, but I don't actually think it's dark and bleak and awful. But nonetheless, I do think that we still have a way to go to get from our current surveillance strategies to a more tailored approach. These are some of the barriers that I think that I've tried to touch upon, the latter of which I didn't touch upon a whole lot, which is reimbursement strategies. That's a whole nother can of worms because, for instance, if I'm an oncologist, and I'm not giving any adjuvant chemotherapy to a patient, why do I want to populate my oncology practice with a bunch of patients who are otherwise just getting surveillance? I'm not going to be reimbursed very well because I really get remunerated for patients who are getting chemo. Same thing for surgeons. But anyway, I just wanted to focus on the lack of high-level data because that's kind of where I'm still stuck is trying to come up with appropriate analyses to truly answer more definitively some of the questions that are out there. And with that, I'll end. Thank you so much again for the opportunity to come here and to present some of the work that I've been doing with colleagues stemming from the University of Washington, carried all the way down to Palo Alto to my buddies now at Stanford. So thanks very much.
Thank you, Dr. Bacchus. What an amazing presentation. It was absolutely great. Before we go to a couple of questions, I do want to acknowledge that we're in the traditional land of the first people of Seattle, the Duwamish people, and honor with gratitude this land. I imagine that Dr. would have a few questions. We only have 5 minutes. Yes, please go.
So, Dr. Bacchus, first, it's really fun and exciting to have you back at the University of Washington. And I look forward to when you're back physically, not just virtually. And I just want to also express appreciation for the work that you're doing. This is important work. You are moving the needle on trying to give us data about what to do with surveillance, where, as you've pointed out, the data is not strong, and you're working on changing that as a true surgeon scientist. I have 2 questions. One is from the beginning of your talk, and it relates to surgeons and the fact that that surgeons have a hazard ratio of 0.3 for performing guideline concordant surveillance, and less than 50% of surgeons actually following their patients. So my first question is, what do you think the role of surgeons are in surveillance? Are we operate and done, or do we have a role in caring for patients long term?
Thank you for that question. I think that we have a very central role to play, or at least an opportunity for so. Any of us probably in our practices know of the patient that's like, 5-6 years out, and you're like, really, we got to cut the cord. Like, you're good to go, you're fine. And they're like, no, I'll see you next year. So the fact that we've entered into this contract of care with them and cut them open, and they've entrusted us to do this, I think is huge, and not completely interchangeable with some of the other providers that they have. Granted, they all usually have a primary care provider. They've got continuity of care with that person, but nonetheless, they all kind of gravitate back to their surgeon. So we're perceived as kind of running the ship, if you will. So I do think that we have a central role to play. And I do think that we're not doing a very good job of it. Anecdotally, of course, when I talk to my colleagues who for the large part are all academicians, they're like, absolutely, I follow my patients all the time, like half my clinic is surveillance patients, et cetera. But I suspect that that's not what's happening in the community. And so there's probably a bit of a disconnect there. And some of that, I think, has to do with that last bit I mentioned with regards to reimbursement. If I'm a surgeon, I make money by operating on patients, not by seeing them at every 15 minutes to look at their CT scan to let them know that everything's fine.
So my second question is at the other end of your talk, which is, so let's say that you're queen for a day and can influence NCCN about what you want them to be saying on their page about surveillance. Now's your chance. What do you want the NCCN to say?
I actually don't think that I would change the guidelines as of yet. I mean, I think that the subtle change that they've made is helpful and a move in the right direction. I think that they are hindered, as there's no indictment of the panel or panels of the NCCN. I think that they're hindered by lack of data. So I don't think that we have sufficient data to change the guidelines in a meaningful way yet, but I'm trying to fix that by giving them more.
Dr. Farja, do you have any questions?
Good morning, Dr. Bacchus. Awesome presentation, and I miss you. I love what you did with the hybrid approach to abstracting nodules with NLP and human abstraction. And my question has to do with that and with the fact that you're now geographically located in the Bay Area, where there are potential industry partners who have a lot of interest in artificial intelligence. And so my question is, have you encountered any opportunities to use AI, or what some people call radiomics, not so much to predict and help clinical decision making, but to help with this measurement problem that we have in research, to find scans with abnormal findings?
Thank you, Dr. Farja. I miss you as well. Your question is spot on. I'm certainly geographically located in a little hotbed for tech and for people who are forward thinkers. I personally have not used that. I can tell you that the various people that I do collaborate with, like Summer Hahn, I mentioned Sylvia Plavridis, they are big time involved in radiomics and how it is that we can do better at the ways that we can harness the power of the radiology and imaging tests that are being done, et cetera. So I know that that work is being done. I've been sort of laser focused on what I've been doing right now, so I haven't had the time or bandwidth to extrapolate to there, but I think your thoughts are spot on, and that's probably where we should be going. I should be meeting more with those colleagues.
Again, I think that we don't have any more time, but I do want to thank you. And I know that Dr. Shetunji also wants to say goodbye. We're going to clinch to the last minute that we can have you here.
Not goodbye. See you later.
No, well, thank you very much, Dr. Bacchus. It was very nice to have you back, and we look forward to seeing you on campus next year.
Absolutely. Thank you very much, everyone. This has been a pleasure, and I can't wait to come visit again up in Seattle. Hope to see you all soon.